Welcome to combined anterior cruciate ligament and anterior oblique ligament reconstruction using the rectus femoris tendon. Surgical technique description. Authors have nothing to disclose. The procedure is performed with the patient in the supine position, and the knee can move through a full range of motion. A padded tourniquet is applied to the tight. Examination under anesthesia should confirm the insufficiency of the anterior cruciate ligament and associated anteromedial rotational instability. Rectus femoris tendon graft harvest and preparation. A 3 cm longitudinal skin incision is made from the superior pole of the patella at the junction of the lateral and middle third, extending proximally. After appropriate dissection, the quadriceps tendon is identified. The graft is harvested from the lateral portion of the rectus femoris tendon, which is the superficial lamina. The surgical plane between the superficial and intermediate laminae is identified around 3 cm proximal to the patella. After 2 longitudinal incisions in the rectus femoris tendon, a 10 mm width graft is created. The rectus femoris tendon is elevated, and its distal end is detached from the patella. The distal free end of the graft is whip-stitched with non-absorbable sutures. The dissection of the rectus femoris tendon is extended proximally for 8 cm using scissors, ensuring that intermediate and deep layers of quadriceps tendon are preserved. A closed tendon stripper is pushed carefully with the knee in 20 degrees of flexion, and the rectus femoris tendon graft is harvested. Peritendon, subcutaneous tissue, and skin are closed. Graft preparation. The graft is folded asymmetrically. The distal portion is folded to form a double graft for the ACL portion. The AOL portion of the graft is the proximal remainder. ACL and AOL reconstruction. The femoral tunnel is made using an outside-in technique. A lateral skin incision of 2 cm is made along the lateral aspect of the distal femur, and the iliotibial tract is split longitudinally. The tip of the drill guide is placed at the femoral footprint of the ACL. Tibial tunnel is made within the topography of the native ACL tibial footprint. Using a suture shuttle, the graft is passed from the tibial to the femoral tunnel. Femoral ACL graft fixation is performed in an outside-in manner using an interference screw with a diameter equal to the size of the tunnel. Tibial ACL graft fixation is performed with the graft tensioned and the knee at 20 degrees of flexion with an interference screw one size greater than the tunnel diameter. The medial epicondyle is identified by palpation. Fluoroscopy aid can also be used if doubt regarding the proper position. A 3 cm medial skin incision is made. A guide wire is drilled freehand, starting at the medial epicondyle anterior portion and aimed slightly anterior and proximal. The remaining graft is passed beneath subcutaneous tissue and shuttled with a suture in the AOL femoral tunnel in the medial side of the knee. AOL graft fixation is performed with an interference screw in neutral rotation and full extension.